Hello, my name is Mark Riley. I'm a medical resident at Albany Med, and I'm presenting the case transthyretin amyloidosis and herpes zoster infection, a mimic of temporal arteritis. We have no disclosures. So, TTR amyloid or transthyretin is a systemic amyloidosis that's characterized by extracellular tissue deposition. Frequently, this manifests as peripheral neuropathy or restrictive cardiomyopathy. But very rare cases of deposition in the temporal arteries mimicking giant cell arteritis have been reported. So our case is an 88-year-old man with a history of non-small cell lung cancer, COPD, and hypertension, who presented to our clinic with a month history of headaches, intermittent vision changes, and left-sided facial pain. About 5 weeks prior, he had been treated for left-sided herpes zoster ophthalmicus in the V1 distribution. On examination, this gentleman was profoundly emaciated with muscle wasting in the proximal and distal musculature with evidence of thenar atrophy bilaterally. He did show evidence of a healed scar on the left side of the face, but there was no evidence of petechiae or purpura on exam. Laboratory investigations included an ESR and CRP, which were markedly elevated, but complete blood counts and metabolic profile and muscle damage markers were all normal. At this point, we chose to treat the patient empirically with high-dose prednisone for giant cell arteritis, and a temporal artery biopsy was done. So on Figure 1 demonstrates the H&E stain of the biopsy, and what you will notice here is that there's no evidence of obvious inflammatory infiltrate, but there is luminal narrowing that you can see here, and then evidence of eosinophilic hyaline material in the media and the intima. Our pathology colleagues stained this for Congo red, which showed evidence of deposits there in those same areas that were suggestive of amyloid. And then in Figure 3, you can see under polarized light that it shows a very beautiful illustration of amyloidosis in these regions. At this point, liquid gas chromatography was undertaken and sent to Mayo Clinic for further identification, which came back as transthyretin type. Additional studies at this point included protein electrophoresis studies, which were normal. In terms of treatment and follow-up, so the patient was referred to cardiology for echocardiography with strain imaging to see if there was cardiac involvement with the amyloid, and treatment options as far as treating this condition are currently ongoing. So in conclusion, although very unusual, amyloidosis should be considered in the differential diagnosis when giant cell arteritis is being considered for somebody with headaches in the elderly population and with facial pain or vision changes. Typically, when amyloidosis is present in this region, it is from light chain amyloid and is associated with monoclonal gammopathies or multiple myeloma. But very rare cases of TTR amyloid have been described, including this one. Additionally, treatment options do exist for TTR amyloid when there's involvement in cardiac tissue or if there's peripheral neuropathy, but no actual treatment studies have been undertaken for treatment with amyloid in the temporal artery. Thank you, and if you have any questions, I'll take them now.